What if I told you that a single phone call completely changed how I practice medicine? My mother, 74 years old at the time, called me from a waiting room and said, "Michonne, they are about to give me a vaccine, and I wanted to ask you before they do." When she described which one it was, I did not hesitate. I said, "Mom, pick up your bag and leave, right now. Do not let them administer that injection." She was bewildered. She said, "But the nurse told me it was recommended for my age." And I said, "Recommended does not automatically mean appropriate for you." That moment stayed with me. Because if my own mother, the mother of a physician, came within minutes of receiving a vaccine that carried real risk for someone her age, then how many other parents and grandparents are sitting in those same waiting rooms right now, rolling up their sleeves, extending complete trust without a single question being asked or answered? And before you make assumptions about where this conversation is heading, let me be unambiguous about who I am and what I believe. My name is DR.Michonne. I am not anti-vaccine. I want that to land clearly. I am not anti-vaccine. I have spent my career in medicine. I have personally administered vaccines. I believe deeply in the value of immunization. Vaccines represent one of the most significant achievements in the history of human health, and they continue to prevent enormous suffering around the world. But I also hold this belief with equal conviction. Not every vaccine is the right choice for every person at every stage of life. And once you move past 60, your body is operating under a fundamentally different set of biological conditions. Your immune system is not the same organ it was at 35 or even 55. Your liver and kidneys process substances differently. Your risk profile has shifted in ways that are clinically meaningful, and certain vaccines that are entirely appropriate for younger adults can become genuinely problematic for someone in their 60 seconds, 70 seconds, or 80 seconds. That is not fear-mongering. That is medicine. That is science. That is what it means to pay attention. Today, I am going to walk you through 5 specific vaccines that I, as a physician and as a daughter, would not allow my own parents to receive after the age of 60. Stay with me through the entire conversation, because some of these will genuinely surprise you. Several are routinely offered to older adults in clinics and pharmacies every single day, and by the time we finish, you will understand exactly why I feel this strongly about each one, and what alternatives may actually serve your loved ones far better. If you find this valuable, please subscribe and share this with someone who has aging parents. This information has the potential to make a real difference in someone's life. The first vaccine I would not allow my parents to receive after 60 is the live attenuated influenza vaccine. The nasal spray version most people recognize as flu mist, and this is the one that nearly reached my mother. Many people are drawn to it precisely because it requires no needle. A quick spray into each nostril and it is done. Convenient, painless, appealing. But here is what most people walking into those clinics never hear. Flu mist contains a live virus. Weakened, yes, attenuated, but alive. For a young adult with a fully functional immune system, that presents no significant concern. The body encounters the weakened virus, mounts a response, builds protection, and moves on. But for someone over 60, the picture is entirely different. The FDA itself does not approve this vaccine for anyone over the age of 49, and yet I have encountered patients who received it without anyone verifying their age or conducting appropriate screening. The aging immune system, through a process called immunosenescence, becomes progressively slower, less precise, and less capable of containing threats reliably. Introducing a live pathogen into that environment is genuinely risky. I have personally seen older patients develop prolonged influenza-like illness following the nasal spray vaccine. I have seen respiratory complications that were entirely preventable, and they were preventable because excellent alternatives exist, specifically formulated for older adults. The high-dose influenza vaccine and the adjuvanted influenza vaccine are both designed to deliver stronger immune stimulation without introducing a live organism. These are what aging immune systems actually need. So if anyone offers your parent or grandparent the nasal spray version, decline it. Request the high-dose or adjuvanted alternative. That is the choice I would make for my own family. and it is what I recommend for yours. The second vaccine I would not allow my parents to receive after 60 is the original shingles vaccine, Zostavax. If your parent received a shingles vaccine at any point before approximately 2020, there is a meaningful chance it was Zostavax, and the concerns surrounding it are substantial. Like FluMist, Zostavax was a live vaccine containing a weakened form of the varicella zoster virus, the same virus responsible for chickenpox that can reactivate decades later as shingles. For years, it was the only available option, so physicians administered it because something was better than nothing. But its limitations in older adults were significant. Efficacy data showed that in people over 80, Zostavax performed at roughly 18% effectiveness. 18%. That is a margin so narrow it barely constitutes protection. And because it was a live vaccine, it carried the same fundamental concerns I described with FluMist. In individuals with any degree of immune compromise, and a considerable number of people over 60 have conditions or take medications that suppress immune function, a live vaccine can potentially trigger the very disease it is designed to prevent. There are documented cases of patients developing shingles-like reactions following Zostavax administration. Here is the encouraging part. Zostavax has been discontinued in the United States and numerous other countries, replaced by Shingrix, a recombinant, non-live vaccine that operates through a completely different mechanism and delivers dramatically superior results. Shingrix demonstrates over 90% efficacy even in adults over 70. It carries no risk of introducing a live pathogen. If your parent has not yet received a shingles vaccine, ensure they receive Shingrix. If they received Zostavax years ago, have a conversation with their physician about whether Shingrix is now appropriate, because whatever protection Zostavax once provided has almost certainly faded. Shingles is not a minor inconvenience. It can produce debilitating nerve pain lasting months or years. It can compromise vision when it affects the eye. In older adults, it can be genuinely devastating. The right vaccine exists. Make sure it is the one being used. The third vaccine I would not allow my parents to receive after 60 is the yellow fever vaccine. I can already hear some of you thinking, my parents are not traveling to tropical rainforests, so why does this apply to me? And for many families, it will not come up routinely. But retirement travel has expanded considerably, and more older adults than ever are visiting South America, Sub-Saharan Africa, and parts of Southeast Asia, destinations that require or strongly recommend yellow fever vaccination before entry. So your 72-year-old father decides to take the trip he has been planning for years. He walks into a travel clinic. They tell him he needs the yellow fever vaccine. And here is where my concern becomes serious. The yellow fever vaccine is among the most immunologically effective vaccines ever developed, and it also carries one of the highest risk profiles of any vaccine currently available when administered to older adults. The CDC explicitly acknowledges that individuals over 60 face a significantly elevated risk of serious adverse events. There is a condition called yellow fever vaccine-associated viscerotropic disease, essentially a scenario where the weakened vaccine virus overwhelms the body's defenses and produces a systemic infection that mirrors actual yellow fever, affecting the liver, kidneys, and cardiovascular system. The mortality rate associated with this condition is estimated at approximately 60%. That is not a figure I can set aside. I recognize it is rare. It does not occur in every older adult who receives the vaccine. But the risk escalates substantially with age and increases further in the presence of underlying health conditions, which most people over 60 are managing. If travel to a yellow fever endemic region is genuinely necessary, the conversation with the physician needs to be thorough and honest. A medical exemption certificate may be available in certain situations. In others, the itinerary itself may need to be reconsidered. I would rather my mother forego a destination than accept a vaccine with a documented, age-amplified risk of a potentially fatal reaction. That is where I stand as both a physician and a daughter. The fourth vaccine I would not allow my parents to receive after 60 is the oral typhoid vaccine, sold under the brand name Vivotif. This one also surfaces most commonly in the context of international travel. For visits to parts of South Asia, Africa, and Central or South America where typhoid fever is prevalent, a vaccine is often recommended. Two formulations exist: an injectable version using inactivated bacteria, and the oral capsule version, Vivatif, which contains a live attenuated strain of Salmonella typhi. And I suspect by now you are recognizing the pattern running through this conversation: live vaccines in older adults. I keep returning to this because the implications are that significant. A live vaccine administered to someone over 60, particularly someone whose immune function is declining, who may be taking immunosuppressive medications for conditions like rheumatoid arthritis or inflammatory bowel disease, or who is managing diabetes, cardiovascular disease, or diminished kidney function, carries a risk profile that warrants serious attention. The oral typhoid vaccine can produce gastrointestinal effects that are more pronounced and disruptive in older adults. It interacts with antibiotics and other medications that seniors commonly take, and its performance data in older populations is less robust than we would want it to be. The injectable typhoid vaccine, while not without limitations, does not introduce a live organism. That distinction matters. If your parent requires typhoid protection for travel, request the injectable formulation. It is a straightforward substitution that meaningfully reduces risk. And I encourage you to use that conversation as an opening to review every vaccine being recommended, to ask whether each one has been evaluated against your parent's specific age, health history, and current medications. A one-size approach to travel medicine is not appropriate care. Your parent deserves individualized consideration, especially when something is being introduced into their body. The fifth vaccine I would approach with the most careful deliberation is the BCG vaccine. BCG, Bacillus calmette-guerin, is primarily a tuberculosis vaccine. In the United States and most Western countries, it is not part of the standard immunization schedule, but in many regions of the world it is administered at birth. Situations where an older adult might encounter it include extended travel to high-burden tuberculosis regions, or in certain clinical contexts where BCG has been explored for other applications. My concern is this: BCG is a live vaccine. It uses a live attenuated strain of Mycobacterium bovis. In a young, immunocompetent individual, this is typically managed without serious complication. In an older adult with any degree of immune compromise, it can produce severe adverse outcomes. There are documented cases of disseminated BCG infection, where the organism from the vaccine spreads systemically throughout the body. This is rare in healthy younger recipients, but becomes a genuine clinical concern in aging or immunosuppressed patients. The presentation can include persistent fever, significant weight loss, and multi-organ involvement. Treatment demands months of anti-tuberculosis therapy, medications that carry their own substantial side effect burden, particularly for aging kidneys and livers. In nearly every scenario I can construct, I would redirect my parents away from BCG after the age of 60. If tuberculosis exposure is a legitimate concern, there are preventive medications, risk reduction strategies, and other approaches that do not require introducing a live bacterium into an aging immune environment. I want to step back now and address why this subject carries such personal weight for me, and why I believe it should matter to you. We exist in a moment of extraordinary polarization around vaccines. One side insists that every vaccine is dangerous and no one should accept any of them. The other insists that all vaccines are universally safe, and questioning any recommendation is irresponsible. I am telling you directly, both of those positions are wrong. The truth, as it almost always does, lives in the space between. Vaccines are among the most powerful tools ever developed in medicine. That is not a debatable point. But like every medical intervention, they require thoughtful, individualized application. And when the patient is over 60, the calculus genuinely changes. Everything I have shared today rests on a single foundational principle. As we age, our immune systems change, and our medical care must change with them. What is appropriate for a 30-year-old is not automatically appropriate for a 70-year-old. Our parents and grandparents deserve advocacy. They deserve questions asked on their behalf. They deserve care calibrated to who they are right now, not a standardized protocol designed for someone half their age. If your parent has already received one of the vaccines I have described, Please do not carry guilt about that. Medicine is always evolving. What the evidence supported a decade ago is not always what it supports today. The fact that you are engaging with this conversation now means you are paying attention. That is what matters going forward. You are now equipped to participate more actively in your loved one's healthcare, to accompany them to appointments when possible, to ask which specific product is being administered, to inquire whether it is live or inactivated, to raise the question of age-specific risk, and to explore whether alternatives exist. These are not confrontational questions. These are precisely the questions that conscientious clinicians welcome. A physician who becomes defensive when a patient or family member asks informed questions is not the physician I would want making decisions about my family's health. A good clinician will walk you through the reasoning, acknowledge the risks and benefits openly, and treat your right to understand as fundamental rather than inconvenient. Let me also be clear about what I enthusiastically recommend for adults over 60, because I do not want this conversation to leave any impression that older adults should approach vaccination with blanket hesitation. That would be the wrong conclusion entirely. The high-dose or adjuvanted influenza vaccine every year is not optional for older adults. Influenza kills tens of thousands of seniors annually, and the right formulation can be life-saving. Shingrix is outstanding, and I encourage every adult over 50 to receive it without delay. The pneumococcal vaccines protecting against pneumonia and related infections are critically important for this age group. Updated COVID vaccines continue to be recommended for older and higher-risk populations, and the TDAP booster covering tetanus, diphtheria, and pertussis remains relevant throughout life. These vaccines are safe, effective, and specifically designed or validated for older adults. They employ inactivated or recombinant technology. They carry strong safety records in aging populations, and they protect against diseases that kill older people at disproportionate rates. Please ensure your loved ones are current on all of them. The message I want you to carry from this conversation is not fear, it is discernment. Choose the right vaccines, ask the right questions, and advocate for the people who trust you to look out for them. My parents gave everything to make me the physician I became. Every medical decision I help them navigate, I approach as though their life may depend on it, because sometimes it does. And I bring that same gravity to every patient who has ever sat across from me. What would I want for my own mother in this situation? That is always the question I begin with, and that is the lens through which this entire conversation was built. If this has been useful to you, if it has prompted a question or a conversation you had not considered before, please share it. Send it to your siblings. Share it with your parents directly. Post it somewhere a family member might encounter it. Information that could protect someone has value only when it reaches them. You have the ability to make that happen right now. I am DR.Michonne. Take care of yourselves, and take care of the people who are counting on you, even when they never say so out loud. I will see you in the next video.